So the Beat AML study enrolled its first patient on November 16, 2016. Using a data cutoff of August 31st, 2018, we've enrolled 285 newly diagnosed AML patients from 12 clinical sites. And as of this morning, we have enrolled 352 newly diagnosed AML patients. I'm going to share with you today the results, or the initial results of our study. So let's start with why. Why a precision medicine approach in AML? Acute myeloid leukemia is the most commonly diagnosed adult leukemia with 20,000 patients a year and an overall survival of 25%. It is also the most lethal adult leukemia. We know now that AML is a heterogeneous disease. It's driven by the serial acquisition of mutations that lead to interpatient heterogeneity, both in biology and clinical response. This, coupled with the increasing evidence of efficacy for targeted therapies in AML, we hypothesized, could we improve patient outcome by matching patients to the appropriate therapy? The Beat AML trial is an umbrella study that requires genomic screening at the point of entry. The primary endpoint is the feasibility of making a treatment decision within 7 days using this information, and the individual efficacy of the sub-studies. Our eligibility criteria is broad and simple. You must be 60 years and older and newly diagnosed to AML. Given the heterogeneity of the disease, we utilize the algorithm that's shown here in making our treatment assignments. The details of this algorithm are presented at this meeting by Dr. Mims. Treatment assignments using this algorithm are based on the dominant clone, defined by the variant allele frequency. All treatment assignments are done centrally, and ultimately, the treatment assignments are made based on what's best for the patient, even if that means an assignment that is outside of the Beat AML study. The baseline demographics are shown on this slide. You can see that it's primarily an older patient population with a high proportion of patients that are over 75 years in age. The answer to the question of can we assign treatment using genomic information within 7 days is yes. We've achieved our primary endpoint of assigning therapy within the 7 days in over 95% of the patients. Looking at our enrollment and treatment assignments, we've enrolled 356 patients based on the suspicion of AML. 66 patients were considered screen fail due to predominantly an alternative diagnosis in myeloid malignancies, such as high-risk MDS and CMML. 5 patients were pending assignment at the time of the data cutoff. We assigned treatment for 285 patients in treatment assignments shown here, and more than 50% of the patients have gone on to therapy. So what happened to the patients that did not go on to treatment? A small proportion, 2.5%, died within the initial 7-day wait period. Another subset of patients went on to standard of care or alternative clinical trial after the treatment decision was made. You remember what I said, the treatment decisions are made for what's best for the patient, even if that means a study outside of Beat AML. And 8% went on to palliative care, which is a special finding from this study that shows that some patients have the time to understand and comprehend their disease and therapeutic options and then choose not to pursue any therapy. The study is large. The study is large. We have 11 sub-studies from 7 pharmaceutical partners, and we're active at 13 clinical sites as of this morning. We covered the prominent subtypes of AML. We continue to expand this collaborative effort and are looking to move into novel combinations in the future. So where are our individual studies today? The majority of the patients are receiving therapeutic benefit, but I'm only going to speak to the studies that are shown or being presented here at this meeting. For our marker-negative group and hypermethylation group, the phase 1b dose escalation combination of Boehringer-Ingelheim CD33 antibody with azacitidine has been completed, and the phase 2 study has been initiated. Details of this are going to be presented by Dr. Bloom tomorrow evening. For the IDH mutated patients, the phase 2 study with enasidenib has been expanded. The initial overall response rate is 44.4% as monotherapy treatment for newly diagnosed patients. This work is being presented this morning by Dr. Stein. And for a core binding factor group, this study has been discontinued. So what have we demonstrated? That a precision medicine approach to assigning therapy within 7 days using genomic information is feasible. Early death and disease progression is relatively uncommon, except in the MLL rearranged AML patients. The majority of patients will go on to therapy, and this continues to increase as we have more studies. And we are seeing promising efficacy in newly diagnosed patients with this trial design. Thank you.